Start, sir.
Yeah. Good evening, doctors. Regards from Bayer Oncology. Myself, I'm Sandeep Kumar. So today we have Dr. Vivek Agarwala, sir. He's a medical oncologist from Narayana Super Specialty Hospitals from Kolkata. Sir will be presenting on recent developments in MHSTC. Sir, over to you. Sir,
Yeah.
I will be sharing the slides from my end. I will be on mute mode.
No, I've already shared the slides.
Oh, perfect, sir. Yeah, please go ahead, sir.
Yeah. So, a very good evening to all of you. And please accept my apologies for a little bit of delay. There was some technical issue with my laptop. And at the outset, I want to thank Bayer for giving me this opportunity. The slides have been provided to me by Bayer. And this is a sponsored talk. So today we will be, talking very briefly on the recent updates on metastatic hormone-sensitive prostate cancer treatment and how doublets and triplets have changed the way we are looking at treatment of metastatic hormone-sensitive prostate cancer with data from Aeronaut study and how darolutamide plus ADT as a doublet treatment is also now a standard of care as also along with the triplet treatment of darolutamide, docetaxel and ADT. So just as I mentioned, this is a sponsored session. These are my disclosures. The slides have been provided by Bayer. And so far as the approval of second generation androgen receptor inhibitors is concerned, in India, darolutamide is approved for non-metastatic CRPC patients and metastatic hormone-sensitive prostate cancer patients in combination with docetaxel, and it is indicated for treatment of patients with metastatic hormone-sensitive prostate cancer as a whole. So this slide, represents the standard of care in metastatic hormone-sensitive prostate cancer and how it has evolved from a single agent ADT to a combination of ADT with either of the androgen pathway receptor, newer androgen receptor pathway inhibitors like the AR blockers, abiraterone, or docetaxel. So we all know almost like a decade ago, only ADT was the way to go for metastatic hormone-sensitive prostate cancer. But come 2018, 2019, now this was clearly established that ADT alone is not a standard of care and is not indicated. It represents an inferior treatment, in fact, for any kind of any patient of any fitness, any age, any PSA, any risk group, metastatic hormone sensitive prostate cancer. If it is a stage 4 hormone sensitive prostate cancer, newly diagnosed prostate cancer, giving only ADT represents an inferior treatment. And this was right way back in 2018-19. And the data had evolved almost. There was 5-year data. It had come first with the charted study where it was clearly shown that addition of docetaxel to ADT remarkably improved overall survival, progression-free survival, response rates, and whatever you call, distant disease-free survival and progression-free survival, radiological progression-free survival as compared to ADT alone. And after that, there have been a gamut of agents that have been added to the standard of care, being endorsed by all guidelines. Stampede came, which showed that docetaxel plus ADT, just as charted, still remains standard of care. And then there was an arm of abiraterone plus ADT. That was also data was released in 2018, and it also showed that yes, abiraterone plus ADT itself also represents a standard of care. Latitude also came in 2017, showed that abiraterone from a second line agent who came along in the first line in ADT. And then there was Enzamet and Arches data. Both of them established even enzalutamide is also a standard of care when it is combined with ADT in metastatic hormone sensitive prostate cancer. Titan came, established apalutamide plus ADT as a standard of care. And this is how all data evolved. And then finally in 2022, the second generation darolutamide was added to ADT with docetaxel, and this triplet became a standard of care. along with the PEACE-1 data, which established abiraterone plus ADT plus docetaxel as a standard of care. And now, darolutamide, it was always tested as a triplet, but now we have the ERASEC and the ERANOTE data, which has established that even doublets are also a standard of care for patients where chemotherapy cannot be given. So, way back here now, almost when you look at patients of metastatic hormone-sensitive prostate care, if they are candidates for giving docetaxel, they are fit for docetaxel. If they have visceral disease, if they have high volume disease, if they are fit enough to receive docetaxel, then addition of an androgen receptor pathway inhibitor like abiraterone as per the PEACE-1 data or darolutamide as per the Arasen's data is the standard of care, and all these patients should rather be given a triplet rather than a doublet. Whereas in patients where chemotherapy cannot be given because of some tolerance issues, preference issues, whatever issues, age issues, if chemotherapy cannot be given, then a doublet treatment of ADT plus any of the androgen receptor pathway inhibitors, whether it is androgen receptor blockers like enzalutamide, apalutamide, or darolutamide, and or abiraterone are a standard of care. And darolutamide is the latest addition to this doublet as per the ARANOTE and the ARASEC data. So, just as I stated that, this was an unmet need. There were other agents were there in metastatic hormone-sensitive prostate cancer, but toxicities were an issue. And definitely there was need for a treatment where chemotherapy could not be given. And there was lesser toxicities, lesser drug-drug interaction potential. So, darolutamide in combination with ADT has transgressed that barrier for all of us with the global phase 3 ARANOTE trial, and this trial even had significant number of Indian patients. And with this, the ARANOTE data, the darolutamide now has the potential to change the treatment paradigm, because it would be the only androgen receptor inhibitor which can be used with or without chemotherapy both, along with abiraterone, of course, which is not a androgen receptor pathway blocker, but a enzyme inhibitor which acts on the androgen receptor pathway. So the background is very clear that triplet is the standard of care, but all patients cannot take docetaxel. And in those patients where docetaxel cannot be given, giving darolutamide plus ADT looked like a potential treatment, but we didn't have a phase 3 data. There was good efficacy and safety data for darolutamide as compared to the other androgen receptor pathway inhibitors. And therefore, this study was designed to evaluate darolutamide plus ADT versus ADT to provide a new treatment option for metastatic hormone-sensitive prostate cancer patients who are not candidates for docetaxel. So this was a randomized double-blind placebo-controlled phase 3 study. It selected around 665 metastatic hormone-sensitive prostate cancer patients who were histologically or cytologically confirmed to be adenocarcinoma of prostate, having a ECOG baseline of PS 0 to 2. And these patients were stratified as per whether the visceral metastases were present or not, and whether any prior local therapy was given or not. These patients were randomized 2:1 to darolutamide 600 milligram twice daily standard dose with ADT versus placebo plus ADT. The primary endpoint was radiographic progression-free survival, which nowadays is like the holy grail endpoint so far as the prostate cancer clinical trials are concerned. OS, mind you, is a very, very prolonged endpoint which might take many years to reach, because nowadays, because of the multiple treatment options, effect of second line and other line treatments are there. And therefore, we need a very good surrogate for OS to be there as a primary endpoint. And radiographic progression-free survival hasn't been accepted as a very acceptable primary endpoint for most of the metastatic hormone-sensitive or castration-resistant prostate cancer patients. Of course, the key secondary endpoints included OS, time to initiation of subsequent antineoplastic treatment, time to CRPC, time to PSA progression, rates of very good response and undetectable PSA deep response, that is less than 0.2 nanograms per ml, time to pain progression, safety, so on and so forth, including the quality of life endpoints like FACT-P scores and time to deterioration, PFS2 and all. Now, this was an open label study until the final analysis, and there were 100% crossover to the open label darolutamide, so that you can understand that because of the crossover, OS is one of the important endpoints for this study, and crossover was done to because it was a very ethically correct study also. Now, these are the baseline demographic and clinical characteristics, and we can see that nearly 30% of the patients in both arms were Asian patients. If you look at the Asian patients and the Western patients, they were all very equally distributed in both the arms. PS wise also, there was a good distribution. Patients who had a high Gleason score represented 65 to 70% of the patients in both the arms. If you look at the median serum PSA at baseline, this was around 21 in both the arms. If you look at metastasis, so de novo metastasis was 70% around in both the arms, and 20% were previous disease with recurrent disease, and high disease volume represented 70% of the disease in both the arms. Around 11 to 12% had visceral metastasis. So these are quite patients who were having high volume disease, but very, very less visceral disease, and prior local therapy was not given to around 80% of the patients. These were quite matching in both the arms. If you look at the APEC representation, so India representation was almost 13 to 14%, which is probably one of the highest representations so far as all prostate cancer patients clinical trials are concerned. So very good and significant representation of Asia, APAC, and as well as India. Now, these are the results of the primary endpoint, and you can clearly see that this doublet significantly reduced the risk of radiologic progression-free survival or death by 46%. There was a improvement of 2-year radiologic progression-free survival from 52% to 70%, almost an 18% improvement, where with a hazard of 0.54 and a significant p-value. If you look at the median radiographic progression-free survival, it was not reached in the doublet arm, whereas it was around 25 months in the placebo arm. If you look at the subgroup analysis for radiographic progression-free survival, very interestingly, you can see that the confidence intervals are simply not crossing over in most of the subgroups, and there is a clear-cut benefit of the doublet in almost all subgroups of patients. And both high volume disease as well as the low volume disease, both seem to have benefited very good. Both with patients with visceral metastasis and non-visceral metastasis seem to benefit. The confidence intervals did cross over actually in the visceral metastasis arm, which represented only 10% of patients. In the black patients, which represented only probably 2% or 3% of the entire patients, as well as in the very high age group patients of 85 years, again, which represented probably only 2% or 3% of patients. So these were because of the very low number of patients. Otherwise, you can clearly say that all subgroups of patients benefited from the doublet of darolutamide plus ADT. So far as the other endpoints are concerned, the overall survival did show a trend towards benefit with a numerical advantage seen, but at the endpoint, at the low follow-up at the time of primary analysis, we can see that the OS data was not mature, but still with a hazard of 0.81, there is a trend towards benefit, although the median is not reached in both the placebo arm as well as the darolutamide arm. If you look at the other co-primary endpoints or the secondary endpoints, you can clearly see time to metastatic CRPC, time to PSA progression, time to pain progression, time to subsequent systemic therapy. All of these endpoints, which are known as good surrogates of overall survival, have shown clear-cut benefit towards the darolutamide arm, even with a significant hazard of 0.4, 0.3. So clearly, the other secondary endpoints, which are good surrogate for OS, shows that it is a very potent and good treatment, and there is a trend towards overall survival benefit even to the darolutamide, despite there being a crossover to darolutamide after the primary analysis. These are again the same endpoints that I discussed. Time to metastatic CRPC, clear-cut separation of the curve with a hazard of 0.4. Time to pain progression, again, clear-cut separation of the curve with a hazard of 0.72. So, important clinical endpoints to the patient, which are good surrogates for response as well as overall survival, have demonstrated that the results are clearly in favor of, significantly and statistically in favor of dalatamide plus ADT. Look at the patients who achieved deep and durable responses. Again, deep PSA response, a PSA response of less than 0.2 nanogram per ml at any point during the treatment represents a very deep PSA response. And this also has been shown to be a very good surrogate and endpoint for overall survival. And clearly, deep PSA response was achieved in 62% of these patients in the daltamide arm, which is a very good, and it represents a 69% improvement in time to PSA progression. You can see that if you look at the time to PSA progression, there was a 69% improvement in this. So there was a very clear-cut improvement in these surrogate endpoints. If you look at the proportion of patients which achieved undetectable PSA or a deep PSA with dalatamide versus placebo in different diseases, both the high volume and the low volume disease, you can clearly see that till almost 1 year time, almost more than 50% of the patients achieved low or undetectable or deep PSA response, and the deep PSA response was all 10 to 15% in the ADT alone arm, but this increased to 44 to 54% by the in the dalatamide arm. And even by the 6 months time, almost 44% of the patients achieved deep PSA response even in the high volume disease. If you look at the low volume disease, the deep PSA response was achieved in almost 82% of the patients, which remarkably shows that probably in low volume patients, dalatamide plus ADT represents probably a new paradigm, a new standard of care, which surpasses all other previous androgen receptor pathway inhibitors because of such deep responses achieved even in the low volume disease, probably in those patients who are not really good candidates for docetaxel based treatment or a triplet therapy. If you look at the proportion of patients which received subsequent systemic therapy or life-prolonging anti-cancer treatments, so this was at the time of primary analysis, there was 32% patients who were received any form of subsequent treatment, whereas this was 42%. So 10% more patients, receiving subsequent treatment in the placebo arm. And if you look at the different treatments, this was again as per the standard of care: docetaxel, abiraterone, enzalutamide, apalutamide, cabazitaxel. Mind you, those patients in the placebo arm, many of these patients, they had switched over to dalatamide so far as when the results of primary analysis was concerned. So this data may further be prolonged. If you look at the treatment emergent adverse events, so this is something which is the most impressive about dalatamide as compared to the other androgen receptor pathway inhibitors, that the adverse events are significantly less. And if you can see, and compared to placebo, look at the results. 90% patients having any form of adverse events in placebo and 91% the dalatamide. So what you can conclude clearly is that there are absolutely no significant side effects, no significant adverse events that are added when the dalatamide is added to ADT. Look at grade 3 or 4 adverse events, same 30% in both the arms. Grade 5 adverse events or deaths, again same 4 to 5% in both the arms. Serious adverse events, 23% both the arms. So what you can conclude is that addition of dalatamide does not lead to any significant adverse events, and that is why on the safety aspect, dalatamide represents a new paradigm of care, a new standard of care as opposed to the other androgen receptor pathway inhibitors. If you look at the side effects that were there, fatigue was one of the primary side effects, class side effects of dalatamide. Look at other side effects like hypertension, which goes to around 20-25% for enzalutamide, which goes to around 50% for abiraterone. This is only 8.5% with dalatamide. if you look at increased creatine, hyperglycemia, increased weight, bone pains, all of these, constipation, hot flushes, which are effects of ADT primarily, these seem to be very much controlled, very much similar as compared to the placebo. And what you mostly see is a slightly higher amount of hypertension, slightly higher amount of class effects, which are not significant at all. So even if you look at the fatigue, and there is absolutely no grade 3, grade 4 fatigue for dalatamide. There is only 5.6% incidence of fatigue as compared to 8.1% for placebo. Look at any side effect; these are mostly similar as that of the placebo. Again, if you look at common adverse events associated with ARPIs. So again, almost all ARPI side effects like hypertension, hyperglycemia, diabetes, vasodilatation, flushing, arrhythmias, rash, fatigue, decreased weight, coronary events, cardiovascular events, they were all almost similar as that of the placebo arm without any higher events that were seen. Also, if you look at the health related quality of life as per the Aeronaut study, so this was also again sent as a separate presentation for ASCO 2025, and dalatamide is the first and the only AR inhibitor to have demonstrated clinically meaningful delays in the pain progression as well as the overall well-being, whereby it was seen that the median time to significant deterioration of the FACT-P total score was 5.1 months versus the placebo. So there was a clearly better quality of life demonstrated, and there was a delay in deterioration of the quality of life with dalatamide as compared to the placebo, which was also significant. If you look at other clinically meaningful delays in other aspects of quality of life like social and family well-being, functional well-being, urinary symptoms, all of these were significantly in favor of dalatamide as compared to the placebo. So, if we may conclude, as per the Aeronaut, dalatamide plus ADT significantly improved the radiographic progression-free survival in patients of metastatic hormone-sensitive prostate cancer, showed a benefit across all secondary endpoints, was associated with a deep PSA response, almost 80% in low volume disease, 50% in high volume disease at the end of 1 year. And these were responses regardless of the baseline PSA. And it is the first and the only AR inhibitor to demonstrate clinically meaningful delays in not only the PSA progression, but also aspects of quality of life like pain progression, overall well-being, including social, functional, and urinary symptom well-being. And it had a very, very favorable safety profile without any significant adverse events as compared to the placebo arm. So with this, docetaxel, without docetaxel, also dalatamide plus ADT represents a standard of care for metastatic hormone-sensitive prostate cancer. So with this, I thank you all for patient listening, and if there are any questions, I'd be happy to answer them. Thank you.
Thank you, sir. I request audience, if any of you have any questions, so please unmute yourself and ask to Dr. Vivek, sir. Also, let me check, sir, if any questions in the chat box.
Thank you, sir, for your wonderful presentation.
Okay. So if there are no questions, I will just say you bye. And if this video, this presentation video, if you can send me, then I'll be really happy to upload it on my YouTube channel. Thank you.
Sure, sir, sure. I will send you in 1 or 2 days, sir.
Okay, sure. Thank you. Thanks a lot.
Okay, sir. Good day. Good night, sir.
Thank you, sir, and thank you, audience, for joining tonight's discussion. With this, I request technical team to end the meeting.
Thank you all the doctors for attending this meeting. Good night.
Thank you.
Good night.